and call it echocardiographic evaluation of amyloid in the heart and something else, because there's something that we've been noticing and working on here that is very exciting, and I really cannot contain the excitement. So I'm gonna share, and hopefully it can spark ideas, and we can then discuss about it. I also apologize ahead of time for maybe rushing a little bit. My clinic actually starts in 10 minutes, and I know I had somebody already there waiting. But anyway, we all know what amyloid looks like. Unfortunately, when it's too late is when it's the easiest to recognize. A patient that not only has a very saturated LV, but has already evidence of significant systolic dysfunction. These patients are already knocking on death's door. Their prognosis is very poor at this point. So we like to obviously find ways to recognize their pathology a lot quicker, and perhaps move away from the invasive traditional route of going for myocardial biopsy, which I admit, as many of those as we do here, is still not a perfect test. We have missed certain patients even with a very thorough biopsy through the septum. So when it gets to that point that you combine the low voltage and the very obviously saturated LV, it's really a race against time for these folks. So we want to see them when they look on the left. In fact, if you can see the screen playing, the guy on the left also has amyloid disease, but you can barely see any kind of saturation of the proteinaceous material in his LV, and everything looks quite normal. We all know pathologically, at the biopsy level, what these things look like. There's dense proteinaceous deposition of light chain protein all over the myocardium, and as years go by, this can create havoc in the natural architecture and structure of our myocardial fiber orientation at all the levels of the heart. There are certain things that make it very easy to recognize. The classic things is when you have, as you can read here, a normal biventricular dimension, but a very concentric thickening, and especially if the patient is not only missing in hypertension, but sometimes even hypotensive, as these patients have low output syndrome from their inability to fill the LV. They have valve thickening, marked by atrial enlargement, usually severe, and a small pericardial effusion, like in this case you see a very thin line of space here with fluid. And traditionally it's a disease that can cause also the worst of diastolic dysfunction, progressing rapidly to a restricted pattern, and that's what we have known to be a dictator of the prognosis, at least when it comes to echo parameters. We have been told that deceleration time and the E to A ratio and the E to E prime ratio is also, the fraction is very abnormal. Here is just a table showing the normal parameters and how they are indeed progressing to some degree of abnormality through our decades of life. So restriction obviously is the worst of the patterns of diastology, and basically when you have a very stiff ventricle where atrial contraction basically fails to move anything. And this is, for example, one of our patients with a very short deceleration time and an A wave that is barely there. And on E or tissue Doppler, the E prime also shows the inability to generate much velocity, on a very, very stiff ventricle. And prognosis-wise, as we know from this very landmark article in the New England Review, the long-term prognosis of patients with infiltrative myocardial disease is very poor. In fact, only second to those who also have concomitant HIV infection, as was published back in 2000, looking at the 10 to 15-year mortality of the different types of cardiomyopathy patients. And so these patients are well known to do very poorly once they have the cardiomyopathy. So on echo, very old article that came in circulation, showing the things that stand out in terms of parameters of ultrasound imaging of these patients. So the E to A prime and the deceleration time and the left ventricular mean wall thickness and the fractional shortening. But in that same reference, very pronouncedly, the deceleration time really showed that there was a group one here that when they have a shorter deceleration time, especially shorter than 150, their 1-year mortality is just terrible. So just in terms of what's echo specific, in terms of prognosis, a restricted inflow pattern and a decel time of less than 150, these patients have a 50% 1-year survival compared to anybody with normal filling pressures who may have a 1-year survival greater than 90%. And similarly, those who have echo features of hypertrophy and symptoms, their 6-month survival is only 50% as well. Now, with more modern technology, this is actually already considered old, and this is an article that looked at the separation of prognostically looking at strain, but this is in the old days of strain. Believe it or not, strain is a new modality, but it already has old technology in the history of it. This is done by tissue Doppler derived strain, which we don't do anymore. They looked at this and they saw clearly that patients with worse strain values, this is again longitudinal strain based off tissue Doppler velocities, their prognosis was significantly worse. So there was a big separation when you pick that number of 13 at the base or 12 in terms of cardiac death and all death, as you can see from this table. So all death at 13, cardiac death at 12 was the cutoff. And nowadays we do strain, as you know, with different technologies. It's speckle tracking technology. So we make the system track the speckles that come on the screen for us, and we can do everything. We can, the systems that are more readily known for this can do, obviously, very easily circumferential and longitudinal and radial, and if you measure short axis views of different angles, from, you can compare the base to the mid and the base to the apex, and the possible combinations, and you can measure rotation or twist or torsion, however you find that name in the literature, and now there are systems that are smarter and can look in the inside and give you the endocardial and epicardial and actually measure the gradient of strain changing from one to the next. So there's a lot of wonderful things happen, but this is very technically dependent, and technology that depends on very good quality images and patients who have normal rhythm and no intraventricular conduction delays to have good quality studies. And there's a learning curve. We started using this in 2007. I think the first batch of sonographers that tried it were, I could call them really good at it from 2009 forward, and that's one of the reasons why our data collection has just started at that point of 2009 and forward. So here, just an example of how the image looks when we obtain at the mid-cavity circumferential and radial strain. And if I have that from the apex, I can compare those and get my torsion in terms of degrees. But, you know, the best of data comes from just measuring longitudinal deformation measurements, and it has become the more reproducible of these measures and the most reliable of these measures. And very quickly, for those who still not very familiar with it, you know, we have a region of interest over the horseshoe shape of the ventricle, and then these tracking regions of interest get to tell you in the frames from aortic valve opening to aortic valve closure. Basically, you get the peak systolic deformation expressed in a percentage point. So it's basically like saying this dot to this dot to this dot, and every possible combination of shortening from aortic valve opening to closing in these dots come to be that negative 19, which you know in terms means that what was you know at 100 millimeters now is at 81 millimeters at aortic valve closure, and we get this very quick and easy by this system we use, and we can get something put all in a polar map. When we look at the apical 2, 3, and 4 views all in order, then we get this polar map. And there are issues certainly with this representation, because when we're looking at mechanical function, certainly you know you can clearly agree that there's 6 you know 6 basal segments and 6 mid-cavity segments, but I'm not so sure there's actually 5 apical segments. And in fact, you know, that's my main criticism, that there is over-representation of the apex, because there's really what they're giving you here is this apical lid, and so to me there's only 4 true apical segments. What they're giving you here is this one is always the average of these 4. You can actually choose to have the pie completed, and instead of 5, see 6 segments, 6 true segments. Because obviously, if you go back to the previous slide, you see that you know we have 2 segments on every apical view. So you know there's 6 pieces here, but in this particular representation, we're doing it the other way. And you know, so there's some issues with that. If you foreshorten an image, for example, then you're basically giving 11 segments to the mid cavity. So you have to be very careful. There's a lot of technical components to getting this polar map made, and you know you can never be too careful, in my opinion, to make this data useful. But once a polar map is made and the average is normal, then you know we're very happy with the results. I also like to say that you know since the apex always in purple and green in this particular vendor system, I like to see that the first lengthening into diastole, I always like to see that in normal patients that is dominated by the either you know purple or green. So to me, to see that is really concordant with a normal person. And so here are more examples. You see always purple and green showing up first, and this is kind of your ENA wave equivalent on the lengthening section of it. And it's important because, you know, like I've said before, in the first webinar that I shared, it is well known that the fibers that go from the AV node straight to the apex are actually faster than the ones that go to the rest of the heart. And so I like to see that, so that I feel like, you know, my apex is also relaxing, is contracting quicker, and perhaps it's relaxing also at a quicker rate, and I think that helps the apex also be kind of the plunger to help diastolically the ventricle and help the pump per se prime best for the next beat. The number we obtain as the average, the GLS, is very powerful, and I'm sure I've shown this before, where in a population of Australians. This is from the group of Dr. Tom Marwick. 542 patients followed for a little bit over 5 years. The baseline characteristics of age, diabetes, and hypertension plus GLS was, in terms of mortality prediction, way superior than wall motion score index and ejection fraction. So in terms of longitudinal mechanics, we know that the heart normal is by many different sources is a -19, so a reduction of 19% in longitudinal dimension, but it's not equal throughout the cavity. Apex is the king of deformation in this dimension, 21. Some papers have reported in other normal populations that the mid is a little bit higher than the base. Here, certainly a little bit different. But just want to make the point that the apex is special, is different, and has a higher number of deformation. And that may tie well to what I've explained before of the apex being actual twisting point for the double helix structure of the heart fiber. So what we have noticed is that in amyloid patients we get a distinct pattern, and the apex seems to be relatively normal in comparison to the segments of the mid and the base. And there was a publication already pointing at this. Came from the group, imaging group in Cleveland, where they compared equally hypertrophy ventricles from groups of patients that had aortic stenosis, and also had another group that had just hypertrophy from chronic hypertension. And these patients look as if they have a pattern that equally affected all of their myocardial segments. Here you see how they kept the 6 apical segments, but here the amyloid patients had a much different pattern, where they saw that the apex was still red, or red is normal, red is good. And I've already heard this in a couple of conferences being called the pattern of the cherry on top of a sundae, kind of looking like just red on the tip here in the center. And we had noticed that plenty. This paper came, I think, showed 30. By the time that paper came out, we actually had about 80 of these patients that had that same sort of pattern, with the apex being preserved. And in this case, it's not as perfect in the 80 patients. You see this patient with the normal sort of color here, leaning to the inferior wall. But I want to show you a couple of cases that I really become interested in here, and there's something that we sort of put up for a series and analysis with my colleagues from stem cell transplant. So, for example, here this is the first scan, the end of September, of a young female who had amyloidosis and was previously treated with bortezomib, proteomes inhibitor known as Velcade, and dexamethasone, followed by myeloablative therapy, and had an autologous stem cell transplant. So the stem cell transplant had been in December of 2010. So this is prior to her transplant, and so she had a very pretty normal pattern, almost a negative 18 for GLS. Now, this is at the time of transplant. Classic pattern, apical preservation. So months after being normal, all of a sudden it looks incredibly abnormal. Now, I have to say that this woman got acutely, severely ill during transplantation, had a pneumonia, had to be in the ICU, treated for sepsis syndrome. And this was how her pattern looked, even though she had just been transplanted. So for us, it was a big surprise to all of a sudden see this. Now, in follow-up, she recovered very well, and this was a year, almost a year later, you can see the days. In follow-up, you see how she recovered. I have to add that at this time, her ejection fraction, when she was very acutely ill, her ejection fraction was in the low 20s. So it was not only that she within a month went from this to this. Her ejection fraction also took a big hit, and she was acutely ill, obviously perhaps truly septic. But within a year, the pattern had gone away and she recovered. The ejection fraction was back to normal. GLS was negative 18. And even further follow-up consistently kept being normal with GLS of minus 18. So it's very rewarding for us to see that, you know, even though she had the substrate of disease, and in a moment of crisis, she truly showed the true colors. Because she was treated with stem cell transplant therapy, we believe, you know, her function recovered much quickly, and she basically looks like a normal heart now. Even years later, now 2013, you see her patterns completely normal now, a negative 21. That's what normal people look like. It's very interesting that you know, the new theory is that the light chain in it of itself is cardiotoxic. There's a lot of there's a big interest in research in this area. This is a reference I show you from Dr. Liao from Boston, who we had the privilege to have here for a grand round. She's good friends of Dr. Ye, my chairman. And she does research with zebra fish heart. So it's very cool because it's a very transparent little animal. And when you inject, you see the heart and you see the shortening of the fibers almost with the naked eye. And when you inject light chain into their medium, you know, the hearts immediately start to beat less strong. And so she's finding that at least in this animal model, there are key proteins in the energy generation, like this thing called stanniocalcin 1, that has to do with mitochondrial mechanisms too. And it's very interesting how now it's shifting to not only the derangement, obviously the deposition for years of the chain, you know, causing direct problems, but just light chain present in the interstitium of the heart itself can be toxic. So it's very interesting and very exciting and very new line of research. Now, I'm not sure you know the case. This is actually a patient from my clinic, patient that I met, and he already looked very saturated LV, certainly in the early stages of mild systolic dysfunction. And you can see here, this is in May of 2012, before his transplant. So he had, you know, like a mini of that pattern, still some red in the apex, but, you know, very poor coloring and deformation. You know, the negative 19 is the normal, so you see his segments here, negative 6, 4, I mean, very poor around the mid, the same around the base. But the apex had the higher numbers. So moving on, he got a repeat study right before transplant, was on 12 of 2012, and this is 11, so this is the month before. Same thing, very poor deformation numbers for the mid. The apex had the little benefit here, but not much. Patient went to transplant in December. Now, 3 months later, this thing starts to come back. See how the apex starts looking really good in red, extending to some of the mid. Patient is doing clinically very well. This thing is getting better as time goes on. You know, now we see a little bit of expansion to the clearly mid segments of the septum anterior, which is great territory, you know, big chunks of the septum. And now this is most recent follow-up. I just saw him in clinic the summer. Now, what was areas of blue, the worst here, now all of that converted into red. So now he's really recruiting, you know, the rest of his heart. It's very cool to see it because you can see all of them now side by side. We're very meticulous with ejection fraction measuring here. Since 2012, I have forced every single body. It had cost me incredible friendships here and my own humor capital to force everybody to do very high quality biplane measurements of the ejection fraction. And you can see that, you know, from here, a 43, a 47, even though the things that are looking better is down to a 45.6, 47, so 50. Not a real change, but the patient is actually feeling incredible. The patient is now up to jogging at this point. The BNP is undetectable almost. It's doing tremendously well. So I'm very happy to see that, mechanically speaking, we have seen that after transplant, you know, his mechanical function has come recovering very significantly, and we can see it, we can palpate this change and see it in, you know, in colors. And interestingly, the other thing that I wanted to share is that very quick and easy, we get the peak systolic strain, but with this system we can also get this thing called the post-systolic index polar map. And I'm very excited with this because basically what it is nothing related to strain rate. For that I have to actually still process separately on an independent computer. But for post-systolic index, it's a quick and easy way. And what I'm getting is, in these raw data images, I would get a percentage of what amount of that peak deformation occurred after aortic valve closure. So knowing that all these normal is 0, at aortic valve closure I want all that deformation to have occurred. So I want 0 after the aortic valve closure. So I had been knowing these polar maps on him, and that therefore I knew that the improvement of these blue segments that he had before was coming now. So that's how I knew this was going to get pink. And I told him that the global number was not going to change much, but now knowing that these are 0, I am thinking that these are going to stay pretty much the same, and where I can hope to see more red is on what's now late. And of course this is all theory. I'm just sharing you in theory the idea behind this. I will only learn when I see him again in a year. This patient comes from very far from the Anderson. That's one of the problems we have with follow-up with these patients, because, you know, they're so unique. So I think, you know, we know that about 40% of all patients that come to the Anderson are not from Texas, and when it comes to amyloid, I think it's 80%. But on that note of knowing from this blue polar map what comes late, I have been learning a lot about physiology, because when I see this, somebody normal, completely normal in terms of deformation longitudinally, but some of it happening late, I think that there's a pattern here that is trying to tell me something. And of course, the main reason we have tyrosinokinesis or post-systolic fractional shortening, or whatever you want to call it, is ischemia, because, you know, it's delayed coronary perfusion in those patients with significant lesions. So you would think when you see this that this patient may have had disease of the circumflex, or branch disease, or an OM, because or anterior, you know, or it's a diagonal or something. You would think when you see that's what this is telling you. However, this is a 29-month-old child. So on children, to see something coming late is something that is not expected. And if it was just one case, it would be one thing. But when I've analyzed 40, 50 of these, and they all have a similar pattern, there is something to be thought about why this is happening. And my own idea so far early in the analysis is that that normal kids have not been exposed to any chemo and have delayed segments, that it's actually an effect of their hyperelasticity, just as their hyperelasticity of the ventricle has been described in normal subjects and even athletes in terms of their diastology. It makes me feel that the elastic ventricle, when it's at premium elasticity, with very little systole, there's some fibers that may have already consumed energy to shorten, but aortic valve closes and there's still impulse on that ventricle to completely, shorten. And this is another case. This is a case where you see a defect of shortening on the posterior base, which is also late. So it's a matching defect as opposed to the previous case where there's an unmatched defect, timing versus strain per se. And now this is a kid that for Ewing sarcoma got already a pretty good dose of anthracycline. So when I see these on young kids who shouldn't have this to begin with, much less something like this, then I start to click and think matching defect, completely atypical at that age. I'm thinking this could be a guy who is going to show cardiotoxicity before the end of his chemo. So it's just a big help. I feel like when I see the polar maps and they come from good quality studies, that I'm being given the gift of extra information. I feel like I'm reading Echo on steroids a little bit. Now look at this, and this is again a patient in my clinic, so obviously it's not a kid. Normal strain in this region, and those segments matchingly are on time. The rest is late, but it's a match defect everywhere. Septum, posterior, anterior, lateral. Now this is a 73-year-old man who has an ischemic cardiomyopathy. So when I see a defect like this, weak and late on somebody who has disease, obviously this is a matching defect, and this is an ischemic cardiomyopathy. So now when I see my colleagues reading, the other day I just passed through the hallway and somebody was reading an echo, and I saw this side by side, and I actually then knocked on the door and said, I bet you're reading the echo of somebody with ischemic cardiomyopathy. I saw the matching, and the guy turned back at me and said, how did you know? I said, just by looking. I don't even have to look at the frames. I mean, I just look at these two polar maps together, and the information is there. I'm not going to miss anything. So it's just kind of cool. It's a little extra help that now you see it in color, and there's that benefit of pattern recognition, just like that pattern for amyloid of the that cherry on top thing. Anyway, back to amyloid. Just a touch about heart failure treatment. These are patients that have a very unique type of cardiomyopathy. Their myocardial cells are there. They may even be healthy. Perhaps there's some toxicity from the direct contact with the proteinaceous material and the light chain, but they don't have what an ischemic cardiomyopathy patient have, and they don't have what a patient with toxicity from anthracyclines have. So they're not the same, and so for a long time we've known that diuretics are the first line of treatment. Obviously, is what helps with volume overload. We have to be careful because sometimes they have nephritic syndrome, and so the need for diuretics needs to be certainly more aggressive. And we know that ultrafiltration has been used in cases of advanced and refractory heart failure due to the restricted cardiophysiology, and that has been successful. And in contrast to other causes of heart failure, of course, there's no data on the benefit of beta blockers yet, or ACE inhibitors or ARBs on these patients. And in fact, some of these patients, have been known to have autonomic dysfunction and neuropathy, and they have very profound bradycardia or systemic hypotension when exposed to beta blockers. So the beta blockers really have to be used with certain caution on them. We see that a lot here in our clinic. And when it comes to diuretics, I don't think they're all the same. As you can tell from this European study, there was a comparison of torsemide and furosemide in all patients with heart failure, and patients who received torsemide seemed to do a lot better in terms of both mortality, that was cardiac and total. So we have noticed that too. We noticed the patients, obviously, with torsemide, you have it costs less hypokalemia. It's better tolerated, less increase on creatinine. We have seen throughout the day the patient have a more even diuresis. So we favor that here. And then there's this. There's the study from the group in Pamplona and San Sebastian that looked at actually objective measures of collagen deposition in patients who needed chronic diuretic therapy, and they compare a group of patients who was put on furosemide versus torsemide, and they looked at collagen volume fraction and procollagen type 1 on serum, and then these patients were clearly in a different path. So collagen volume fraction from the myocardial biopsies, the patients were on furosemide had no significant decrease in time, and the patients on torsemide actually had a significant decrease in time from collagen in the tissue. So we do favor these patients to be on torsemide as opposed to furosemide. Obviously, they need it. And now, just to point out and sort of harp on this pattern recognition from the polar maps, you see here on the screen on the left what I just showed you of amyloid cherry on top, and now I show you the complete opposite. Apex here is gone. Anybody?
Looks like a myocardial tendon.
Yep, and the apex is not moving. So on the right, what you had here was Takotsubo. This is this patient here. Apex on vacation. Just the tip of the apex. So we actually prepare a case series of this too. We have now over 30 patients that we've shown that early in the presentation of Takotsubo have this pattern, the apex gone, and I call this the evil eye pattern. We submitted for a case series. It's actually been already accepted. So it's a very different look from an LAD pattern. This has been published, how the LAD, when it's proximal LAD, looks like. I still cannot say that a distal LAD disease would not look like that, but the patterns of each coronary disappearing is very typical on a polar map. But so we know that the apex is very special. It's kind of the theme of what I've been saying, and here I show you again the spiral look of the fibers, how they twist and they form a real knot and twist at the apex. This is a high resolution CT from a cow injected with high pressure air into the ventricle. So a very nice illustration from that movie, The Helical Heart. It's on YouTube. And to get romantic, it's obviously the figure of nature. The double helix is everywhere in life. I want you all to see that movie again, and that's why, being that the apex is so special, I keep saying, to our loved ones, you always say, love you from the bottom of my heart, when you, cardiologically, correctly speaking, should be saying that you love them from the tip of your heart. Thank you very much for all your attention. If you have any questions, feel free to email me. I hope you guys enjoy that.
Very good. Thanks, Jose. That's quite a lot of detail there. I think we actually have a large amyloid program now, and so I don't know if there's any differences between AL amyloid and TTR in terms of imaging. I'm not sure if there is or isn't, and because the pathophysiology of the light chain deposition is a little different.
Yeah, we have a few. I haven't analyzed all of them and compared. The problem had been that we are not a single vendor lab, and so a lot of these, even the ones we recognize, get done on a different system, and so it's very hard to reconciliate. So but now it's the era where other software can analyze from any system, and I haven't finished and compared, to be honest, but I would anticipate that there's got to be a good pattern to alert too, and I'm very excited about looking at the post-systolic index abnormalities, and kind of help me, be my red flag when everything else doesn't really raise my eyebrow on something.
Eric, I don't know if you have any comments about all that.
I don't know if anybody's there.
We're here. He stepped out. No, that was a great talk. Thank you so much.
All right. Well, it looks like your last slide, you're announcing your meeting in November.
Yeah, we have it every 2 years or so. Like to extend an invitation to everyone. We only have 40 minutes of imaging for the 2-day conference, so it's not, obviously we have a very minor role in it, but then the basic stuff and the more clinical stuff gets discussed, and it's a good meeting, short, sweet sessions, and hope those of you who can make it can visit with us.
We'd like to ask to see if any of the other people here would like to ask any questions. I know you have to leave, Jose, but we do have Dan here, who also runs a very active amyloid program. So we'd like to throw it open to the audience for comments and ideas.
Oh, here you see the attendees.
Yeah, so I mean, I think that we have yet to, I haven't been able to get the full implementation of strain rate imaging, on all the echoes that are being done, like you're doing. So we don't have as good a session of, serial measurements in an individual patient. So I think, that's a big problem for us.
Yeah, but once somebody is trained, it spreads, and so it took us, I would say, like 18 months to get the technicians, into it, and and to be honest, the systems do have their quirks. We use GE. I have no disclosures with them. I specifically refuse to be on any kind of speaking bureau and that kind of stuff. And but I like their product. I think it still needs a lot of work. I'm not entirely in agreement of how the segments are represented, and also the way to make it easier, you have to make a lot of functions automated. Like for longitudinal strain, they have that, but they don't have any such shortcuts for strain rate or circumferential radial and torsion. You have to sort of do those offline, and in a place now we're doing 70 echoes a day. There's just no way that you can expect for us to process all of that. Some of it has to be done bedside, and be ready so that it really slaps me in the face when I'm looking at a study. So.
I have a quick question. Can anyone hear me?
Yep.
Yeah.
All right, great. Hi, Isaac Ray. I work with Indiana University with Dr. Feigenbaum. We have just recently done a study and submitted it for review, looking at about 30 patients and their serial echoes, all of amyloid, receiving various therapies. And we've noticed that responders, particularly with Velcade, you can see a nice correlation with their BNP levels and their strain. But the TTR patients, which don't necessarily respond much to Velcade, they basically maintain their poor cardiac status and have a progressive decline. Have you noticed any kind of trend with modalities of treatment and the subsequent strain?
Yeah, that's the thing, that I was sort of mentioning before. I mean, I hope none of your TTR patients are getting Velcade, but
They're not.
The problem is that in our amyloid program we've seen that where somebody has some proteinuria on their urine test and they have severe LVH and maybe they get a fat pad biopsy and it shows amyloid, and so then they automatically treat with proteasome inhibitors. That's we've seen a few patients like that, and so it's really tricky. And as a result, for routine purposes, we send off fibrillary typing in patients that end up getting a biopsy, and that's the only way that you can clearly show that it's not an AL version versus a TTR version. And then the other part is that we're participatory in several studies looking at new treatments for TTR amyloid. So I think that finding out differences in how imaging can help you or serial biomarkers can help you in those patients, I think is really important. And I think your observation that you just said you submitted, I think, is really quite important.
Yeah. All right, thank you.
Now that's very interesting about the biomarkers, and that's fascinating actually. That looking at that correlation, we haven't seen that actually. We're in the middle of analyzing the more than 80, I think, now that went for transplant. What we have seen, we try to see that recovery played out, and what we have seen is that there is a difference, obviously, because on those who go earlier for transplant, the recovery is really more obvious.
Does anybody else have any comments or questions?
All right, I'm off to clinic. Thank you, guys.
All right, thank you so much.
Okay, thank
Appreciate
you so
it,
much,
Jose.
Jose. We'll keep in touch. Dan, do you have any messages for the group this morning?
Yeah, well, we'll send out an email to everybody, but we did finalize our plans for our annual meeting, and actually we were trying to make a strong connection with our Eastern European folks. So there is the 2014 ICOS annual meeting will be in Prague in October, and we'll send an announcement out to everybody about that if they can find a way to get there.
What Wednesday is that going to be in October?
October 9th and 10th.
October 9th and 10th in Prague.
Yep.
This October, right?
Yes. And then the other piece is for anybody who's going to the European Society of Cardiology. We're still trying to finalize plans to have a dinner meeting there to talk about cardio-oncology issues, and we haven't quite got a venue yet, but so there'll be an announcement about that for anybody who happens to be going to Barcelona.
Very good. We'll put the announcements on the ICOS website for all of this information. Is that up already on the Prague meeting, Dan?
I think John said he emailed yesterday that says that is up there, but I haven't personally seen it yet. But he did it last night, so yes, I think it is.
Okay, great. Well, thank you, everybody, and we'll see some of you at the steering committee meeting on the 4th Thursday of the month. That's still standing, is that right, Dan?
Yes, the 28th. Thursday the 28th.
Great, great. Thank you so much. Glad
All
to
right.
have
Thank you,
everybody.
guys.
What a great time.
All right. Thanks. See ya.